All right, so let's talk about it real quick. So the classification is correct. The risks, I think you did pretty well. There may be a one or two little things missing, but I don't think they'll care.
Mm.
And then so for the nutrition, I don't think there is a difference between someone who is obese versus not obese. You would still do a ratio of I think it's like 40, 40, 20,
Mm.
40 of carbs, 40 of unsaturated fats, and 20 of protein. I think that's the standard.
Sure, sure. And
Um,
for and that goes for the diabetics too, or that's different?
uh, I'll have to look it up,
Mm. Okay.
but yeah, I don't think it changes. I remember that lady talking about it. The band lady. One of her.
Oh yeah, 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 yeah. She's
Yeah.
really good. Yeah.
Uh-huh. And then for the C-section, so the surveillance is correct, 36 and 34. And then for the C-section, you can use something called the Alexis O. I don't know if you guys use that. Um, have you heard of that before?
I heard of the Traxi, and we have like something like sticky things that go on the abdomen, and you
Oh
just like
yeah, so you can either
give them
tape,
anesthesia. Yeah.
you can tape the penis upward
Mm.
with just like adhesive tape. The Alexis O is just like a self-retaining retractor. It's like a it's like a big circle bag that you can put it into the you can Google it. It's called Alexis O.
Cool.
And
Yeah.
then also you can do that super umbilical incision. I didn't know it was you do the C-section through the fundus afterwards. I have to look it
Yeah.
up.
Yeah. I had one attending who
Uh,
did it in
really?
residency. Yeah, he did. Yeah, he was a
Abdominal
beast.
incision. Let me cause I remember I just saw a picture of that thing. Is it just called
Oh, Alexis. Yeah, dude, I know the Alexis, of course. I use it
supra
all the time.
umbilical incision obese the cesarean super umbilical. I think you still make a lower uterine segment
Yeah, I mean that's what
incision.
I saw from the attending. So, but yeah, I guess it's going to be really hard to reach the lower segment either way.
Yeah, you're
But
supposed to like pull the penis down instead of pulling it up. Um, and then you can reach the lower fundus that way. All right. Anyways, and then um the Lovenox is 40
yeah,
milligrams daily, but if their BMI is greater than 40, you're supposed to do a weight-based dose. So it's a
like
po-
1.5
yeah
milligrams per kg Q12.
0.5 milligram per kg.
0.5. Okay.
Yeah, Q12. Yeah,
Okay.
yeah. Uh, okay. That's pretty much
That's
it
cool.
for obesity.
Nice. So, where did you get that 0.5? Because I've been looking for it everywhere. Up to date or
I either up to date or the practice bulletin
oh, cool.
because I it's on my note, so I don't know exactly where
Yeah,
I got
sure,
it.
sure.
But yeah,
Yeah, that's cool. All right.
yeah.
You want to do one more or?
Yeah, sure. Uh, let's see. What do you want to do? You want to do asthma?
You join our office. Sure. Yeah. I haven't done asthma at all. Yeah, we can do asthma. I need to read about it, so I'm gonna make up a lot of stuff.
Okay. All right. So, um, do you know the asthma severity classification?
Yeah, so there's mild sporadic asthma, uh, and there's moderate persistent asthma, uh, and there's like intermittent asthma, mild persistent asthma, severe persistent asthma, and severe asthma, or like the severe asthmatic attack, uh, a refractory asthma, I guess. But there's four grades to it.
Okay. Um, how do you diagnose asthma?
Asthma is diagnosed by basically formally it's diagnosed by spirometry, or like a spirometric study, but usually in clinical practice, it can be diagnosed clinically, and with like administration of treatment, with like improvement of symptoms.
Okay. So, um, what would be your let's say this patient has um, uh, mild persistent asthma. So,
Mm.
but she uses the rescue steroid. I mean, not rescue. The rescue
Inhaler.
albuterol inhalers, and
Mm.
it's not helping her. What would be your next line of treatment?
Yeah, I would then consider administering, assuming the inhaler is a beta agonist. I would then
Yeah,
consider
albuterol.
administering. Yeah, I would then consider administering a muscarinic antagonist inhaler, such as ipratropium. And with failure of that method, then I would consider inhaled steroids.
Okay. So what's the first one that you said?
Ipratropium.
Apotropian? Apotropian. Okay.
Ipratropium, yeah.
Yeah. That would be the first line or the second line?
That would be the first line. Yeah.
Okay. All right. Let's say the patient comes to the ER with a acute asthma attack. How would you assess the patient, um, and also when would you decide to keep her in the hospital versus discharging her?
Okay. I would present to the patient's bedside, evaluate her vital signs, listen to her chest. I would perform an ABG as well, and I would and my history and physical. I would also inquire about her history of prior hospitalization for like an asthma attack, if the patient like ever needed to be like intubated, or like admitted in the ICU for an acute like asthma attack, then I would perform an ABG, and I would expect to see hypoxemia as well as hypercapnia, or hypocapnia, hypocapnia, and then I would also perform, and I would also be mindful that this patient needs to be placed on like oxygen therapy, and I would administer albuterol ipratropium nebulizer sessions, as well as inhaled steroids, I would also be sure to consult my internal medicine colleagues and emergency department colleagues, so they can like assist me with the management of this patient at this time.
Okay. Um,
Is she pregnant? Is this patient pregnant?
yeah, of course. Why,
Uh,
otherwise, why do we care?
all right.
Not
Oh
your
yeah, that's
problem,
right.
dude.
Oh yeah. What if? Oh, you're absolutely right. Yeah. So I would also be mindful that if we monitor the baby, uh, the tracing might have some like abnormalities, and I would be more patient with these changes until the patient's general condition is stabilized, and I would then reevaluate the antenatal testing or the fetal heart tracing or whatever is the case.
Okay. Let's say, um, let's say this patient. So, is there any? Would you do fetal surveillance on this patient
Uh,
with moderate or severe asthma?
I wouldn't if her symptoms are well controlled with outpatient management. I would monitor the fetal growth, every 4 weeks during the third trimester, but I wouldn't perform antenatal testing purely for asthma.
Okay. All right. That's pretty much it. Okay. So let's go over it.
Sure.
So, um, ipratropium is not first line for someone who's pregnant. Um,
Oh, it's not? Okay.
no. So, uh, so the categories are intermittent, then mild persistent, moderate persistent, and then severe persistent. So that's the
Got
four
it.
categories. Um, and then if you have mild persistent, there's a during pregnancy, the exacerbation rate is about 15% versus moderate is 25% and severe is 50%. Um, the diagnosis, what you said was correct. So it's based on symptoms, wheezing, chest cough, shortness of breath, worse at night, and then when you give a bronchodilator, she gets better. So that's a
Mm.
diagnostic of asthma. Um, Normally, you will use spirometry, but you can also just use the peak flow meter is sufficient.
And it's
Um,
less than 80, right?
yeah,
80% of
80,
personal best, right?
yeah,
Yeah.
80% of person breast, right?
Sure. Cool.
And then so the first line for mild persistent asthma is budesonide. It's an inhaled corticosteroids at a low dose, 20 mics every 1 to 3 puffs. That's the first line. Then if you have moderate persistent, it's still budesonide with a medium dose, and then you can add the long-acting beta agonists such as salmeterol.
So Metro, yeah.
Yeah. And then if you have severe persistent, it's high dose inhaled corticosteroids um, plus the long-acting um, beta agonist.
And so for the intermediate, you do the budesonide and
So
the salmeterol.
intermediate, you just use albuterol, right? The short-acting rescue.
Mhm.
And then there's mild persistent, moderate persistent, and severe persistent. There's the
Oh,
yeah,
for the moderate persistent one, what do you use?
medium dose inhaled corticosteroids.
Medium dose.
Yeah,
Okay. Yeah.
plus a long-acting beta
A
agonist.
long-acting beta
Yeah,
agonist. Okay. And it's all budesonide, but
right.
different doses, right?
Correct. Just different
A low
pumps.
dose, medium dose, and
High
high dose.
dose,
Okay.
right.
Cool. Cool.
And then you just add the long-acting beta agonist. So and then for if that doesn't work, you can give theophylline,
Hmm.
theophylline, and also chromalin. I don't know if chromalin is the same as whatever the one that you said, ipratropium. I don't know
Is it
anything about asthma.
Chromalin? You said what
Yeah,
was it?
chromalin or theophylline.
I know theophylline, but I don't think they use it anymore. Let me
Uh,
see.
I mean, that's what
Oh,
the
yeah, yeah, yeah.
the
No, I'm just
yeah.
Chromalin sodium
Um,
oral inhalation. No, that's not ipratropium. No.
no.
Ipratropium is basically, I think there's like a combination medication that has both albuterol and like ipratropium. It's ipratropium. Uh, it's
Mm,
uh, uh it's like a muscarinic antagonist. So it's like the opposite of the parasympathetic system, so it
yeah.
causes dilatation. But let me see. I'm looking it
Family.
up on up to date. Pregnancy referred to individual monographs. Okay. Yeah, I'm not sure too. I need to look it up. I'm not sure if
Yeah.
it's safe with pregnancy or not. But
Yeah.
yeah.
It's Atrovent.
Yes, exactly. Atrovent. It's
Atrovent. Yeah.
it's Atrovent is the Combivent. Yeah, is the trade name that has both albuterol and the ipratropium.
Uh huh.
Or like Atrovent is the same probably. Yeah.
I mean, the Food and Drug Administration said um
Atrovent. Yeah,
it's
you're right. That's what it's called.
have been conducted in pregnant women. Animal study are not always predictive of blah blah blah. Should be. I didn't really say anything about it. All right, we can look it up later.
Hmm.
And then so for the acute asthma assessment, it depends on their forced expiratory volume. So the peak flow meter, right? You can use the peak flow
Hmm.
meter to decide whether or not their um, you know your rescue treatment is doing well or not. So
Hmm.
if the FEV1 is greater than 70, and then the baby is looking good, category 1,
Hmm.
after an hour you can discharge them.
Hmm.
But if they are less than 50, if the FEV1 is less than 50, they should be hospitalized.
Okay.
And then if the PCO2 is greater than 42, um, they should be in the ICU.
Hmm.
And
Cool.
then yeah, and then you discharge them on a oral corticosteroids, and then taper them off. Um, and then uh, my note says you're supposed to do serial growth scans at 32 weeks for moderate to severe
Hmm.
asthma.
Cool.
Yeah.
That's what I'd say.
Asthma. Yeah. Other than that, that's pretty much it.
Cool. And is this from the practice bulletin? Like,
Mm-hmm. Yeah.
I think that was a practice bulletin, and I read
There
like I think
is.
this was the first one that I read in residency as a resident.
I
My
think
first ever practice bulletin.
they renewed it or whatever they do.
Oh, okay.
Yeah.
All right. Cool. All right.
You want to ask me something?
Yeah, sure. So you have a patient who's an 18-year-old seeing you in the office for her first GYN exam, and she smells like cigarettes. How would you how would you counsel her about smoking cessation, and what are some of the medications you can use to assist her and things like that?
Yeah, so, oh, is she pregnant or no?
No, she's
Oh,
just
she's
an
not pregnant.
18-year-old smoker. Yeah.
Oh, okay. So, for someone who's smoking, I would apply the 5 A's methods. I will usually work it into the conversation, basically asking them about their smoking history, and also advise them on the side effects or adverse outcomes of being on smoking, and also I would assess them on their willingness to quit. If they are, uh, if they have the intention to quit, I would try to assist them in gathering resources, and also arrange them with support groups, and possibly uh, start them on treatment. And in terms of treatment, usually we can do either nicotine patches or Wellbutrin, um, and also what's the other name? Uh,
Chantix or
yes, Chantix. Yes, yeah,
uh,
those are the
uh,
medications.
Varicocil. Yeah.
Yeah, those are the medications that I'm familiar with.
Okay, cool. All right, and what's like? What are some of the risks that she can have as a smoker? How do you like counsel her and things like that?
Yeah, so I will counsel her that smoking increases her affects her in many different ways, um, starting from kind of the top of her body. She can increase her risk for cerebral vascular uh, events, cardiovascular diseases, lung diseases such as COPD, lung cancer. She can also have oropharyngeal cancer, head and neck cancer. Um, then she can also have gastric cancer. Um, it also increased her risk for ovarian cancer, bladder and cervical cancer. She also, if she's trying to get pregnant, it can decrease her chance um, of getting pregnant. Um, when she
Nice.
gets pregnant, she can also get she's at risk for ectopic pregnancy, um, and during pregnancy, she's at risk for stillbirth, miscarriages,
Abruption.
right, placental
IUGR.
abruption, yeah, IUGR. Uh, she's
Preterm
also
birth.
at
All
yeah,
everything.
preterm birth, and also oral. She can also have oral cleft abnormalities.
Cool. Cool. Nice. All right. Nice. Yeah. Very nice. Cool. I sent you like a thing, like a diagram with the five R's and the five A's. Usually for patients, for these scenarios, you can start with the five R's. So like you can ask the patient, like if she feels if this is of like relevance to her, what are the perceived risks of smoking? What are the possible rewards that she can get if she quits? What are some of the things that are stopping her from quitting? And then if she's willing to quit, then she will be, then you will be done with the five R's, and then you can go to the five A's: ask, advise, assess, assist, and arrange. But yeah, I think the guy in the course said something like these things you can be very personable. Like you can say, I spoke to the patient and she was willing to quit, so I give her like a 1-800 number, and then I call her the next week to follow up with her and see how she's doing. You know,
Mm-hmm.
that's that's also a good answer. But I think this is very high yield to like
Yeah,
drugs
for
and
sure.
smoking and like depression and things like that. That's going to be asked a lot. Yeah,
Yeah, yeah, for sure. Yeah.
cool. All right, you want to do one more? It's going to be a quick one.
Yeah, sure.
All right. So, when can you give the HPV vaccine? Like, what's the usual age of vaccination, and how many subtypes are there, and what are they?
So HPV quadrivalent vaccines. Wait, it's not quadrivalent. It's
It's
nine-valent.
not. It's nine.
It's about nine-valent vaccine contains nine different uh, subtypes of HPV. 16, 11, not 6, 11, 16, 18. 31, 33, 45, 52, and 58. Um,
Nice.
so you can give her.
And did you notice? So sorry, but did you notice that like those are eight? Because I did count them, and they were like, wait, what the fuck? Those are eight.
Oh, there's only 8? Wait.
Yeah. So
6, 11, 16, 18, 33, 31, 33, 45, 52, 58. That's 9.
oh, that's nice.
Yeah.
Wait, 1, 2, 4, 6, 8. Oh, sorry. So sorry to interrupt you. I'm so stupid. I apologize. I can't count. Yeah, sorry about that, man.
Okay. All right. So, and then you can give them, if depends on their age. So before 40, before 15, they only need 2 doses. At 0 months and 6 months. After 45, I mean, after 15, they will need to receive 3 doses at 0, 2, and 6 months, and they can get it up to the age of 45.
Okay. Do you give it to everyone? Like after the age of 45?
You mean before the age of 45?
Yes, before the age of 45. There.
Um, yeah. So usually I recommend the vaccination uh, on everybody if they are before the age of 26. After 26, it will be shared decision. A shared decision. Um,
Making.
it will be shared decision making, since the efficacy of the medication does decrease, since these patients are more likely to already contracted some of the HPV subtypes.
Okay, cool. Nice. Yeah, very nice. And what's the catch-up time for that vaccine? You know, there's something about a catch-up thing. Uh,
Catch up thing.
Catch-up vaccination for that's what you were talking about. So for like adults aged 27 to 45, catch-up vaccination is not routinely recommended. The decision to vaccinate this group should be made on an individual basis. Yeah, so that's the catch-up period. But like classically, you would give it before someone's sexual debut. So
Right.
like before they start their first intercourse, basically. You know, that's the
Mm-hmm.
best time to give it. Yeah. Cool.
Right.
Nice, man.
Wait,
Yeah.
but
Good.
for the catch up time, is it after 26 or just any time after sexual debut?
27 to 45. That's the catch up because I think the old guidelines said you can't give it like after
Up to
like
26.
26.
Right.
Yeah, but now they extended it to 45, and that's why it's like the catch up. So if you didn't get it in your normal age, you can get it later, you know, and like the normal time, you can get it later. That's why
Okay.
you're catching up to it. Yeah.
Right. Okay. All right. Sounds
All
good.
right, cool, man. Thank you for you
Yeah,
know
yeah,
like
of
doing a little
course.
bit of studying this late. Yeah, I know you're probably like
Anytime. No, I would have been studying
got you out
anyways.
of bed. Okay.
Yeah,
All
not a
right,
problem.
dude. I'll talk
Cool,
to you
man.
later.
Yeah, let
Maybe
me
if you have
know.
like time tomorrow or
Yeah,
something.
yeah,
Yeah.
let me know. I'll be studying this whole week.
All
Yeah.
right, man.
All right.
All
I'll
right.
talk to you later.
Talk to you soon. All
Okay.
right.
All right,
Sounds good.
bye.